Thank you, Gordon. Thank you. Yes, Richard Freund, SUD program manager and the Office of Behavioral Health. Typically, I've been overseeing special projects, which include various trainings. It also includes the media campaign for Options, which is a great program featuring liaisons throughout the state. This season, I'll be helping with the summit and organizing tabling. We just had a great event a couple of weeks ago at the Sea Dog game, where it was Mental Health Awareness Month, and Gordon and Director Squirrel got to throw out some pitches and be part of a really good awareness campaign that the Sea Dogs were promoting. So that was a fun way to carry good messaging, and as does the Options campaign and the liaisons, and part of the naloxone distribution program, and get to see that work and the value that it has. And I'm really great to be here today, and can't wait to hear the panel. Thank you, Gordon.
Thank you, Richard. We're lucky to have you as one of our newer additions at the Office of Behavioral Health. Let me just finish our discussion on the Governor's Summit. Again, the registration materials are out. We've already had between 300 and 400 people register. We hope to have 1,200 people there, which would be consistent with some of our prior summits. We have 24 breakout sessions. The keynote speaker is Dr. Miriam Delphin-Rittman, who is the administrator at SAMHSA in DC. She's a former commissioner of health in the state of Connecticut. And this will be the first time that Dr. Delphin-Rittman's been able to be with us. We'll also have the U.S. Attorney, the Attorney General, the Governor, and a panel of 4 people from out of state that will also, including Tracy Green, the epidemiologist at Brandeis, who's really the nation's leading expert on drug checking, and 3 other of her colleagues around the country that will talk about things that are happening in other states that we should arguably take a look at. So we hope to see many of you there. There's 70 resource tables available for your organizations. And there are, small registration fees to attend and also to be a resource table. But we don't, in the case of attendees, anybody can apply for a scholarship. We don't want that $50 fee to be a barrier to anyone who wants to attend. So keep that in mind. It's just a box you can check for a scholarship if you should need one. So hope to see many of you there. Hopefully it'll be a beautiful day in Auburn, and this will be the first time that we've done Summit in the Lewiston, Auburn area. On to our accidental drug overdose review panel. This was legislation that I proudly, humbly drafted in the year 2000. We finally got it to the legislature in 2021. It was that pandemic era, and it was one of the bills that was left in 2020 when the legislature had to abruptly leave town. And but we got it passed in 2021. The governor signed it, and we started appointing people to the panel. I think we had our first meeting around August of 2021. So we're now nearly 3 years into it. And after 2 years, we produced a report that you have in your hands that we sent over to 4 committees of the legislature. Many other states have similar panels. Ours is a little different in that it's statutory. And we also have the ability to look at not only fatal overdoses, but non-fatal overdoses as well. Now, we've been busy enough with some categories of fatal overdoses that we wanted to look at that to date, we've not used that authority in the statute to, in fact, look at non-fatal overdoses, which when we do, it really gives us one huge advantage over the cases that we have, and that is that if they're willing, we'd be able to talk to the individual who overdosed and is still alive. But again, what I want to share with you now is kind of why we do this, why we enacted the statute, what the protections are in the statute, how we get the work done, and then I'm going to turn it over to two of our 16 panel members. I chair the panel statutorily, and we all have been appointed for 3-year terms. In the document that you have listed all the current 16 members of the panel. There are physicians, there are researchers, there are public safety officials. There's a chief of police, there is a sheriff, there is the commissioner of public safety. And we have harm reductionists as well. It's really a terrific group of people who I've been enormously impressed. We almost always have 100% attendance, even though we have 3-hour meetings, and these are really busy people. So I'm very appreciative of their effort. In a short form, I think what I tried to describe is what we do, that it's a deep dive into a case. And rather than just looking at the numbers of people who overdose each week or how many people die each week, and if you want, by the end of the call, we have any time, I can bring you up to date on what those numbers are. You already are well aware that our numbers are fortunately declining of late. But it's really powerful to be able to dig into a case rather than just have a number, and to basically ask ourselves the question, well, this 31-year-old young man, what who tragically died of an accidental overdose, what was his life like from the time he was born to the day he died? Where did he go to school? What interventions were there? Was there a genetic disposition to substance use? Were there social issues, environmental issues? And, not to give you the conclusion before the end of the program, but what we find, that we had a case this morning, in fact, that we brought this up again, that it's the social and environmental factors of ACEs, trauma, are so pervasive that and the attempts at treatment, it is so chaotic, that life, that you actually come away with the conclusion that I frequently do, that this is a miracle that this individual made it to age 31. That's how difficult these lives are frequently. And so we do it to not only look at all of that, but also to make recommendations based upon what we learn in that review. Our researchers at the University of Maine, associated with the Margaret Chase Smith Policy Center, they look at thousands of pages on every case, because we get all the treatment records, all the school records, all the OCFS records. We have the statutory authority to get just about everything we need. And by the time it's presented to us in a summary form, it's still dozens of pages. The cases today, the summary was 54 pages. And that was from excerpts of thousands and thousands of pages. I think there were like 35 sources of material for the particular case this morning: treatment centers, schools, jails, social service organizations, etc. But again, we formed the panel, and the legislature passed it in order to do a deep dive, but also to recommend to state and county and local agencies ways to prevent these deaths as a result of accidental overdoses. And I'm reading from the statute. These methods could include modification or enactment of laws, rules, policies, and procedures. It's the panel's role to examine a subset of deaths associated with these overdoses in order to facilitate the development of targeted recommendations. The examination takes into consideration the demographic and social determinant characteristics of the population of individuals whose deaths are associated with overdose, so that racial, ethnic, social, economic, and other factors are considered equitably in the case. The best example that I can give you are the first subset of cases that we chose to look at, which were individuals who had been recently released from jail and died within 30 days. In the past, it's been well documented that people exiting, being discharged, individuals from incarceration who had a substance use disorder were many, many times more likely to die in those days following release than other people with a substance use disorder. I want you to know in Maine that has vastly improved since we started treating individuals for substance use disorder in the jails and in the Department of Corrections in 2019. We also do a much better job at discharge with people normally getting naloxone as well on their way out the door. And we have more case managers. We have the wonderful Maine Reentry Network that works in some jails. We're not 100% where we need to be, but it is much better, to the point where in 2022, I don't have the 2023 number, but I need to get it. Our overdoses, only 1.7% of our overdoses that year were people who had been recently incarcerated. However, we looked at 5 of those cases and made recommendations to the jails and the sheriffs as to how they could be prevented. Those recommendations are set forth in this report. In the course of looking at those cases, by the way, we realized that actually 17% of overdose victims in 2022 had been in a hospital within 30 days of their death. So we became very interested in, well, what happened in that hospital? What were they there for? Did anyone, and again, I don't want to be seen as throwing Maine's hospitals under the bus. Many of them have really stepped up and are doing a great job at what we're asking them to do. But nonetheless, we know that there are occasions, of course, where a person may come in they may be in an ED because of an overdose, or they may be in for endocarditis, they may be in for medical conditions from years of injecting drugs. But for whatever reason they're in one of our licensed hospitals, we want to ensure that if the hospital knows of their substance use disorder, that they are asked about treatment and given resources for treatment, including a rapid low barrier access to buprenorphine in every emergency department. The third set of cases we looked at was tragically adolescent cases, a 14-year-old and 2 15-year-olds. It's very rare for us in Maine to have a fatal overdose under age 18. But when it happens, it really affects the community. Not that every single death doesn't affect the community, but when it's individuals, adolescents who are so young that they do not have a substance use disorder. They've not been old enough to develop a substance use disorder, and instead they're just experimenting and likely had no idea of how lethal the drugs are that they were dealing with. We're now looking at some cases involving recovery residences that Dr. Springle's an expert in. And we're going to look at some cases involving veterans. And again, after we look at each segment of cases, we always then make recommendations. The work of the panel is confidential by statute. These are not public deliberations like they are at the Recovery Council, which I've become so familiar with, when we are subject to the right to know law. where our work is confidential for obvious reasons, to protect the confidentiality of the individuals and their families. In acquiring the information, we sometimes uh, uh, seek to talk with family members or friends if they're willing. It's all voluntary. And we have found that generally speaking, not universal, but generally speaking, people love to hear from us because it's an important part of their processing. It's the kind of calls I get in the governor's office. People don't want to think that their loved one has died and nothing good is ever going to come from this. And so many people volunteer. We have people that open recovery centers. They really it's an important part of their healing process. So Ron is going to talk to us about and maybe Shelley Yankowski may be with us too in the audience, and Shelley may have a comment. Shelley is an affected other, and Ron is a person in recovery, and they have a particularly beautiful way of working with these families and talking to these individuals and hearing the things that we might not see on paper. So I think the only other technical thing I want to mention is that how pleased we are that virtually every treatment provider, every school, every social service organization, we send them a copy of the law that shows that we have the right to the information, and they do everything they can to provide us with the information. But that's also not universal, and we do sometimes get pushed back and have to do some significant 42 CFR Part 2 work or HIPAA work and convince these organizations that no, there's plenty of exceptions for this type of research, public health work, and we're entitled to the records. So, but our staff does a terrific job. We have contracts with the University of Maine people. And finally, promise this is the last thing. We have two people going to a national meeting in Minneapolis next week. There is an organization that brings together review panels. Many of them are not on a state level. Many of them might be organized by a chief medical examiner by county. States are different, but there are many. I would guess there's probably somewhere between 25 to 40 such panels that exist around this country, and obviously it's great benefit to all of us to sit down with people doing this work and learn from each other. And so we have Dominic and Stacy from our staffs going to that meeting next week. So, Ron, without further ado, I'm going to ask you to talk about your role. Anything you want to add about the history? You've been an appointed member of the panel ever since our first meeting. We're very appreciative of your work because you bring a lot as a person in recovery and as a physician who treated people in addiction, and now your role with the Maine Association of Recovery Residents. You bring an awful lot to the table, and we appreciate that. But I'm going to turn it over to you, and then we'll go right to Natasha.
Thank you. Yeah, I have an identical twin. Natasha has my same name tag, which is a quirk of the of the new Zoom system, I think. Thank you, Gordon. And I would be remiss if I didn't at least make one comment about the contributions that you have made to the state of Maine, not just the Overdose Review Panel and your leadership. You mentioned that we have a reduction in the number of overdose deaths that we're recording each year, both last year and also the trend this year is downward. And that's not for no reason. We're one of 4 states that in 2023 has seen a reduction in these overdose deaths per capita. And there are reasons for that. But there's no one reason that I think anyone can point their finger at. Because if there was one, then we would be putting all of energy and efforts into that thing. But it's not one thing. It's so many things. It's having the 21 recovery centers now, whereas 6 years ago we had 2. 8 years ago, we had no certified recovery residences. Now we have over 80. We've distributed 500,000 doses of naloxone through the government's efforts, through Governor Mills. I mean, one thing after another that we can talk about, the OPSIS program, decreasing stigma. Stigma is still a gigantic problem. We still see that literally every day. Someone wants to open a recovery center in a small town, and there's pushback immediately, and it's a struggle. But most of the times, we're able to prevail. But it's still alive and well. I'm sad to say. But stigma kills people. It prevents people from identifying that they have an issue and receiving the help that they need, and makes it more difficult for them to remain in sustained recovery. Gordon mentioned that Shelley Yankowski and I, members of the panel since the beginning, have particularly worked in the area of next of kin interviews. If you look around the country, there's only 6 or 7 states that have a statewide review panel like we do. New Hampshire is the closest one to us, but very few of them actually do detailed, in-depth interviews with next of kin, essentially as many as can be identified in any given case. And the UMaine folks work tirelessly to develop a list of those people and make efforts so we can get their contact information, so Shelley and I can reach out to them. And we've been doing this now for some time. And I'll get to that in just a second. But interviewing next of kin is not like anything else I've ever done as a medical professional. Now, I was an emergency room doctor as my first work when I graduated medical school and residency. And so I had lots of opportunities to meet with people who had just lost a family member. But that's not next of kin interviewing. That's just really dealing with people who are in shock, trying to deliver the news, explaining the circumstances of their death as best you could, and usually only having about 5 or 10 minutes to do that. It's not grief counseling. It may involve referral, but next of kin interviewing is so much more. It's so much more that the UMaine folks suggested that both Shelley and I, who volunteered to do this work, that we receive some formal training from the Bureau of Justice Assistance. They have an overdose fatality review program, which is a number of hours of training that was so illuminating for both of us and so valuable. I mean, we're both empathetic people. Shelley lost, 2 of her beloved children, Adam and Sean, to this disease. And I've had numerous friends, dozens, maybe hundreds now, that have perished from addiction. But the skills that are needed, this compassionate type of conversation with these family members, even it may be years later after their loss, they're still grieving, and discussing these things in detail and answering open-ended questions that we pose to them can really be an act of bravery on their part. But as Gordon indicated, most of the family members we reach out to are more than eager to share with us. They do feel that the information they might share after we explain the purpose of it can perhaps benefit another person, and they're very willing to do it. Matter of fact, we think they may be an untapped resource in helping to work with other family members who are dealing with living family members who are suffering from addiction and alcoholism, and be a resource for us. But they do find, we think, that there is some meaning that they can add to the loss of their loved ones. The overdose fatality review training program, not to go in great detail, but it gives vignettes and case studies so we can practice what our interviewing techniques might be. Things I wouldn't think of, like being aware of anniversary dates of a loved one's demise, or maybe their birthday or their first holiday without them, things that we might not think of. A lot of helpful phrases, ways to be empathetic but not overly maudlin, for example, and being able to ask open-ended and non-judgmental questions and not bring our own biases. Shelley and I begin the interviews by talking about ourselves, and that I'm a person in recovery, that Shelley has lost people, and it develops, at least in the very early parts of the interview, a lot of trust. And in a minute, I'm going to ask Shelley to chime in also with her views about that. The one thing that we did learn, though, is that vicarious trauma is a real thing. Now, as an ER doc, I saw lots of trauma, and you kind of build up a wall about it so you can do your work. But reviewing hundreds, even thousands of pages, which is literally an American Horror Story, where you think about all the sadness and the trauma and the horrible things that people go through before they finally die of this disease. That that reading all of that over and over again, could stir up things that I have inside of me, and most of us have inside of us, the traumas and sadnesses that we've experienced. And so we are alerted that vicarious trauma is a real thing. All the panel members have been, because that's that part that goes with the territory. I also want to talk about another of the danger zones that we discovered in doing this work. Gordon mentioned leaving jails and prisons. Incarceration is certainly one, for various reasons, often related to the reduction in a person's tolerance to the particular drug. Also, people that have just got out of the hospital for a related admission. But one that I think surprised some of us was that a number of the cases we reviewed reveal death from overdose, just before they're about to access treatment. That literally the night before, the night before treatment is a danger zone. It's not the night before Christmas, it's the night before treatment. And people die, the last hurrah, whatever you might want to call it. Well, I'm going to treatment, I'm not going to use again, so let me have one more episode of that. And that we've had a number of those cases that we've identified that. So all treatment providers there, if you're referring people to inpatient treatment, residential, whatever it might be, making sure those people are not alone in those hours or days before they enter residential care would be important. The other thing is that from a financial point of view, we're talking about lives, not dollars, but the message that we could save so much money for every life that is saved. That's a person that is not literally spending millions of dollars, that mostly taxpayers' money, in the medical care system and the criminal justice system. These reviews, again, sometimes thousands of pages, reveal hospitalizations. And when I look at the procedures that people go through, and the medications and the length of stay and the months of inpatient antibiotic treatment for infected valves and such, just avoiding one or two or three of these cases a year would pay for pretty much anything you want to do in this field. It's truly remarkable. And I don't know that we actually have a price tag. I know there are estimates for how much substance use disorder costs us, our country, and our state, but it's an enormous amount of money. So let me stop with that and turn it over to Shelley for a moment to add any comments about our interviewing. Or Shelley, anything else you wanted to share? And Shelley's not on camera, but I know she'll be able to join us. Shelley, you should be okay if you unmute yourself. We're not hearing Shelley. Is that right?
Right, we're not. I'd probably move on to Natasha, Ron, okay. And Shelley has put some really poignant notes in the chat, and people have access to them.
We'll try and get back to you, Shelley. Okay. District Attorney Irving.
Thank you. And I think hearing from Shelley's really an invaluable resource. The folks who have been in the trenches, as she said, it's important to have that perspective, but those are folks that we need their perspective to move forward. They often need to be doing this work probably to move forward, but the folks that they serve really understand that they're credible messengers here. So I started on the overdose review panel, replacing Jonathan Sarbeck, who was not reelected as district attorney from Cumberland County. And I was asked to be the representative for the Maine Prosecutors Association. So the Maine Prosecutors Association consists of the 8 elected district attorneys and the Attorney General's the Attorney General. And we're law enforcement, right? We're the prosecutors of the state. We file all the criminal charges. all those state criminal charges in Maine. And we have a diverse view on many issues regarding the criminal justice system. But something that I think the vast majority of folks in law enforcement, including prosecution, have come to realize that jail and prison are not healing people from the disease of addiction. We're not equipped to do it. Now, we're prosecuting folks often who are addicted and committing other crimes, and we're trying to make sure that we're acknowledging that. So this review panel has been, as Ron noted, the vicarious trauma. These are hard cases to look at. We're looking at human beings' lives who very often were very, very difficult lives. And as Gordon said, it's a miracle that they made it as long as they did. And we're looking at data. We're letting the data lead us, right? Because we need to know, what the numbers say, not just what we think anecdotally. But we also need that perspective of the folks we've lost. We need to remember the stories, and we need to look at each individual to see where we did intervene, and what worked for a time, and what didn't work. So what we see in the vast majority of the cases that we're reviewing are trauma. And we see that in the majority of our cases for the overdose review panel. I see that in the vast majority of the cases that I prosecute, that the folks we're often prosecuting have lived through unspeakable trauma. And that is what is the initial step into addiction, into a life that is ultimately very, very difficult. We see childhood trauma, including violence to other family members, violence to these children, to these people when they were children. We see sexual violence. We see multi-generational family trauma, mental illness. We see things like veterans who've come home from war, who've come home from service to our country and have experienced extreme trauma. And that seems to be a huge current that underlies so many of our cases. As Gordon noted, we also have seen cases of children overdosing. Unfortunately, we've seen folks who think that they're using recreational drugs and experimenting, and those drugs, unfortunately, today are poison. And you're playing Russian roulette anytime you're using an illicit substance that's a street drug. That's just the reality today. We have seen folks overdose who did not have a long-term standing substance use disorder. We've seen a very large current also of people with co-occurring disorders. Maybe that's mental health, often again, PTSD and other mental health or mental illnesses. But we also see co-occurring disorders such as, dental disease. We see obesity. We see eating disorders. We see diabetes. We see hepatitis. We see people often in generally very poor health. Over and over, we're running into folks who don't have transportation. We live in a rural state, and either because they don't have a driver's license or they can't afford a car, they are not able to get to the places they need to go and access the places that they need in order, potentially, those life-saving treatments. We see folks who are in treatment. I mean, most of these folks, we always say treatment. In the prosecutorial world, law enforcement, we want treatment. We want folks in treatment. The reality is, a lot of the folks who are overdosing and dying are in treatment, have been in many different types of treatment, have been successful for a time. But the reality of this disease is that there are reoccurrences and relapses. And we, as a people, right, we need to really grapple with that, and balance that when we're engaging folks in the law with law enforcement and in the criminal justice field. I'm going to say that my greatest wish, having been on this panel for this amount of time and being the elected prosecutor for 4 counties, is that we can't fix this problem when somebody is 30 years old, when somebody is 40 years old. It's wonderful when people achieve recovery. We need to support the citizens of Maine and the people who live here. We need to support them in recovery. We need to make sure we destigmatize this disease as much as possible and make sure that we give folks a soft place to land as much as possible. But we are not going to fix it when somebody's 30 or 40 years old in the vast majority of instances. We need, as a state, as people, to invest in children. Again, the vast majority of these folks were lived through very, very difficult childhoods, neglect and abuse, and those issues can stay with a person and do stay with a person lifelong. So I think the biggest lesson that I've had, again, in my career as a prosecutor, but also, it's just reinforced through this panel, is that investing in universal child care, from birth, right? We need to invest in our people from the day they are born. We need to know the folks who are experiencing trauma from the very beginning, and we need to do everything that we can, including universal childcare, universal early childhood education, universal preschool, making sure that we're supporting children and families in recovery, and that we can say that we're doing everything we can to avoid the absolute sadness and suffering that these folks have survived, and to never have to tell a parent again that they've lost a child, to not have to tell a community that they've lost a community member. And I believe that most of our problems in law enforcement start when these folks are children and they are victims, and we need to support them throughout their lives. So those are a lot of the takeaways I've had in this panel, and I really appreciate the work of Gordon Smith. Is just fabulous, really dedicated and knowledgeable, and he takes us where we have to go, even if those places are difficult, even if they're questions that we don't want to ask ourselves, right, about what harm reduction is appropriate to explore. The staff are incredible. They must do so much work to compile these summaries. As Gordon said, they're hundreds of pages long. The full reports are hundreds of pages long, and the summaries are over 50 pages long. And the amount of work that they're doing and the dedication and the knowledge and expertise they have, these are folks who, all of these folks who are doing this work and are on this panel, care very deeply about helping some of the most vulnerable people in our state. So I feel honored to even be able to be a part of it, and try to be part of a solution to this really, really sad problem. But there is hope, because through the work we're doing here, we're able to identify where we have holes, and we're able to really identify, again, childhood. That's where it starts. Put the money there. So we're coming up with some answers. We just are going to need to publish that, right? We're going to need to, and then we're going to need to make sure that we have legislative efforts to fund what we need. So, thank you.
Well, thank you, Natasha, and thank you for your kind words. I think all the members on the panel will really share a lot of the points that you and Ron have made. So, Marina or Richard, are there any questions? I've been following the chat, but I'm not sure where the questions and answer pieces are.
Questions, yeah.
Okay, so let me take you through the recommendations that are that we've made so far, that are matter of public record. Some were related specifically to cases where the individuals had left the jail and died, and others were general recommendations that from all of our cases. And a lot of, because we looked at the cases involving incarceration first, a lot of these recommendations have not only been taken to heart, but been implemented. For instance, we asked that all law enforcement provide naloxone for their patrol officers to carry. The legislature in 2022 and 2023 enacted a law requiring that, and now they do all carry. The next recommendations were that all EMS clinicians offer leave behind naloxone to any individual, family members, or friends who are on the scene following successful resuscitation and a subsequent refusal of transport to the hospital. 30% of cases now, roughly, the individuals refuse transport once they've been revived. So the only connection we got is the people that are there on the scene. And we had to pass legislation to authorize EMTs to, in fact, be able to offer a Narcan or a naloxone kit to take home. Obviously, they had been well trained to administer naloxone, but their statute and their medical protocols were not broad enough to allow them to actually have a conversation with the individual or their family or their friends and give them a kit to take home, which was at the point at which could there possibly be a more important time to do some harm reduction and have that conversation. So now that's done. The project, all the EMTs take a brief online training to do that, because again, it's kind of like the training that Ron talked about that BJA does for people to talk to people who've lost someone. You may be the most highly skilled EMT in administering naloxone, but your ability to interact compassionately with that family at that point in time or that individual under very stressful circumstances may in fact not, you may not have the training to do that. So they do some training, and it's been mandatory since last December that in every case where there's not transport, the person be offered naloxone. There's been some pushback that some people don't want to do that. But again, we work our ways through that. And it's the law, and it's there, and we have great support from the Office of Emergency Medical Services and the new director, Will O'Neill, to make sure that that is honored. The other recommendations regarding the release upon after incarceration, of course, the most important one was to make sure that people with a substance use disorder are treated while they're incarcerated. That did not happen until 2019, and we still lead the nation. I would say, along with Rhode Island and Vermont, and increasingly New York, which passed a law requiring that individuals, in fact, be treated for the substance use disorder. We, of course, not only had it in Executive Order number 2, but we also had the lawsuits from Smith versus Gillen up in Worcester County, federal lawsuits that resulted in a declaration of in the Federal Judicial Region 1, which includes all of New England and in Puerto Rico, that declares that in this region you have a right to be treated for your illness, whether that's a behavioral health illness or whether it's a more common medical illness. So again, the last time I looked, 44% of the residents in our Department of Corrections, for instance, facilities were on some type of medication for substance use disorder. That is undoubtedly the highest in the country for a state Department of Corrections. But we but it's also probably still not reaching all of the individuals who need to be treated, given that we believe that at least 70% of individuals incarcerated in this country have a substance use disorder, along and with many of them with along with co-occurring conditions. So these were again the primary recommendations with respect to those cases, along with more case managers, because the case managers that are working with the individuals, there aren't enough case managers to really prepare each of the individuals for discharge. And we recognize that when you're talking about the county jails, it's far more difficult than at the Department of Corrections, because we don't know when the people are going to be released, and they might be there for a night, or they might be there for 9 months, and everything in between. So we know it's difficult, and we've tried to make more resources available to for the jails to provide the kind of treatment that is really state of the art and standard of practice, including $4 million in the supplemental budget that will be used additionally for that purpose. Rather than take you through the general recommendations, as all of you have access to the report, I think there's at least one question that I saw somebody had a hand up. Can anybody access the question of the individual who had raised a hand?
Yes, it says, given the ever-changing drug supply that continues to get more toxic with each new iteration, prescription medications to heroin to fentanyl to xylazine, would a safe supply pilot ever be considered for a recommendation?
Yeah, that's a great question. I get a lot of questions about safe supply as well as safe use sites. Safe supply would be meaning giving people an opportunity to test their drug, regardless of how it's been acquired, so that they know what's in it before they use it. Now, to some extent, xylazine test strips and fentanyl test strips come close to that, but there are some other new equipment. Our Project Dharma has some drug checking equipment. It's the kind of thing that Tracy Green, the epidemiologist at Brandeis, will be talking about in her panel at the webinar at the Governor's Summit on July 25th, because she really is the nation's leading expert in drug checking. So a short answer to the question is, would such a pilot be accepted, be considered? Of course it would. We'll consider anything that we think keeps people safe, keeps people alive, whether it's harm reduction, or urging people into recovery. And in fact, based upon what I just mentioned, the program, the educational program at the Summit and Project Dharma, we are absolutely getting into that field, as well as the 2 types of test strips that I mentioned. So thank you. It's an excellent question. The supply, it's very difficult for our law enforcement and public safety people to stay ahead of the cartels and with respect to what is out there. There was a report. I don't have I don't know if I can pronounce this drug correctly. Ron might help me. Medetomidine. Medetomidine is now a new poisoning the supply in places like Philadelphia, Chicago. There were a huge amount of it, and we've not recently in these cities, and there were alerts put out about it. It's a sedative. It would have some of the same implication as xylazine, likely to make it more complicated in resuscitating a person. And but we've not seen it in Maine. But if it's out there in these other places, we will see it. And so again, the source of the drugs are changing all the time. And drug checking would be one way to help would be a standard harm reduction activity that we certainly should consider under some circumstances. Any other questions, Richard, that you see there?
No, there are not right now.
Okay, so I'm going to finish up on the general recommendations before thanking our panelists and signing off. One of the recommendations generally was to raise awareness of the Good Samaritan law. We have seen more than one case where people waited way too long to call 911. In one of the cases, the well, I want to be careful about talking about individual cases because these are small numbers. But suffice it to say that
Please, I don't know what you want.
Yeah, that in one of the adolescent cases, colleagues of the adolescent panicked, and at least a half hour went by before they alerted an adult that had Narcan in the premises, but it was too late. Fentanyl works, as Dr. Sword keeps telling us, it works very quickly. And so, and the Good Samaritan law is part of it. Now in that particular case, the young people were not old enough to be thinking about the implications of, well, if I call 911 and when you do that in Maine, the police come. Frequently, the EMS come right afterwards. And people are afraid that they're going to violate their probation, they're going to be arrested. And the Good Samaritan law, we have a very good Samaritan law that does not happen. Not, yes, it's got some exceptions to it, but generally speaking, if you're trying to keep a person alive and you call 911 and you assist that person, then based upon the arrival of the police at that occasion, any evidence at the site at that time cannot be used against you. It is arguably the strongest Good Samaritan law in the country. That's not coming from me, the state's director of opioid response. It's coming from the advocates who are very proud to have passed it. So that was one of the recommendations, that we can have the best laws in the world, but if nobody knows about them, then they really don't achieve their purpose. The other thing, we get right into prevention. We talk about early intervention in the schools, some of the things that Natasha talked about. We know that even delaying that first use, the evidence is very clear that if a person's really struggling and tempted to be using when they're 11, 12, 13 years old, the likelihood that that person's going to develop a severe substance use disorder is high. If we can delay that use, best case scenario, till say they're 23 or they're 21 or even till they're 18 and 19, each year that we're able to delay that first use, the likelihood of severe substance use disorder is greatly diminished. And then we talk about warm handoffs, and we talk about the role of our options, liaisons, and referrals. So again, we're out of time today. I hope I'll see a lot of you at the Governor's Summit. I want to absolutely thank Dr. Springle and District Attorney Irving for their participation today. Really, I think this is one piece of the puzzle. It's, and we're just gonna, we're very pleased that some of the numbers are looking better, and we're just going to continue to do all the things that we're doing, but do more of them and do a better job of getting the word out that recovery is available, that more resources are available. We have detox available in Maine tonight, but we're not doing a good enough job for people to know where those beds are and that they're available. And I think we have a real problem with the fact that for so many years people have tried to get a bed and not been able to, that they've kind of given up. And so I want you 110 people left with me today to get the word out that we've got beds. We've got nearly 100 beds now, and they're not full. And so even if you've tried it before, try it again, because now we have beds. It's not perfect. We probably don't have enough beds after people successfully detox to get into residential treatment, but we are building a system gradually. And now we realize that we got to let people know where we are and that people are available. All right, we're going to let you go. Have a great weekend, and hope to see you at the summit. We will not resume these monthly webinars until September. We've got 4 great programs all lined up for the first Friday of each month in the fall. So thanks again, Ron and Natasha, Richard, Lorena, always. See you soon, and thank you.